we're excited to present this to you guys. We are a new group over at UW Health. Over the past 6 months, piloting a small hub and spoke program, and part of the team is going to help present some of the stuff that we've learned and talk about on a regular basis with patients. So next slide. Is it the whole screen? Are you guys seeing it okay? Okay, perfect. So kind of the agenda for this next hour is, again, we just kind of went through the introduction, and then luckily we're going to have Joe do a short video for us, go through some definitions and language and some resources, kind of talk a little bit about the future of harm reduction, and then Katie's going to end with how to use the UW Health navigation or how to prescribe PrEP, and then we're going to have a little short time for discussion. So, get my notes here. So we all kind of know what harm reduction is. You know, we kind of have been talking about this for a long time, especially people that are here working with addiction. You know, abstinence is not for everybody. It is a little bit more of like an old school or traditional model. So harm reduction is for individuals who are not abstinent from substances. So kind of what we are going to talk about is how to keep these patients who are currently using and how to keep them safe. How do we decrease their risk of death? How do we decrease medical complications and decrease financial and legal complications? So we are going to start off with our peer support specialist, Joe Galey's video.
Perfect, thank you. Let me try to cue it up here. Give me 1 second.
You know, without harm reduction, I would not be alive today, and I would not be able to help others realize their potential and that recovery is possible. I struggled with mental health conditions and coped with life by using substances for 20 years, nearly ending with a deadly fentanyl overdose. When you watch this presentation and go about your day, please think of not only your patients, but your loved ones and coworkers as well, because the opposite of harm reduction directly affects everyone. There are 4 pillars and 6 guiding principles to reference, but no universal definition of or formula for implementing harm reduction exists. You know, first and possibly the simplest thing we can all do is become aware of the language we use and understand stigmatizing language, albeit mostly unconscious, promotes guilt and shame, which prevents motivation for conversations and motivation for change. You know, simple things such as saying use instead of abuse, person who uses substances instead of addict or junkie, positive or negative instead of clean or dirty can go a long way. You know, after hearing it for so long, I thought I was dirty. I literally felt dirty after using and felt completely worthless, and the shame prevented me from asking for help. You know, even in the workplace, I hear things like, man, that person has got some issues, or that person is kind of crazy. You don't think anything of it at the time, but a coworker might be suffering or have a loved one who is suffering, and now they are ashamed or afraid to ask for help. Harm reduction or harm minimization is a scientific and evidence-based practice with a range of public health policies and procedures designed to lessen the negative social and or physical consequences associated with various human behaviors, both legal and illegal. Now, for example, sexual activities and substance use. Harm reduction includes access to fentanyl test strips, Narcan, safe syringe programs, safe consumption sites, condoms, STI testing, glass stems for people who smoke substances, and basic health care. You know, as you can see, there is no one definition, and you might hear the same things over and over when we're talking about harm reduction. But that's what got us to stigma and shame in the first place. It was repeating patterns learned from agreements made from people who came long before us. You know, it no longer works, and we need to all make new agreements and repeat it until it becomes normal. I often hear people say harm reduction only enables people and is sending the wrong message of promoting use. The only thing harm reduction enables and promotes is honest conversations, linkage to care, people to stay disease-free, and it enables them to be seen, to have autonomy, to have power, worth, self-value, and so much more. Harm reduction allows for the reduction of HIV, Hep C, and various other STIs, along with overdose fatalities, emergency room visits from abscesses and infections from unhygienic equipment. It reduces harm and provides basic quality of life and dignity for not only the individual suffering, but families and communities. You know, at its core, harm reduction means meeting people where they are without judgment, stigma, shame, or bias, and provides life-saving resources, basic health care, and dignity with compassion and empathy. Brené Brown says, in order to empathize with someone's experience, you must be willing to believe them as they see it, and not how you imagine their experience to be. You know, I have been coaching in a new recovery for 5 years, and it took me quite a while to get harm reduction down. I always felt sorry for what others were suffering in silence with, so I always wanted to fix their problems. My inner advice monster always wanted to take over, instead of just creating a safe space with empathy and love. Something I also heard a lot goes a little something like, you know, well, Uncle Buck's daughter just lost her leg, and all you lost is a cell phone. I'd be grateful if I was you. You know, we must not feel sorry for or minimize other people's experiences. We must truly meet people where they are and believe them as they see it. You know, I strongly urge you to examine your own bias, unconscious bias, and judgment surrounding stigma and harm reduction, and ask why places implementing harm reduction are seeing almost no overdose-related deaths, less crime and incarceration, more treatment engagement, people healing from trauma, families and communities being rebuilt. And here in America, we are currently trying to make a special federal classification for fentanyl to further criminalize, stigmatize, and dehumanize those currently suffering the most. I am calling you all to action and asking you to examine what we are doing wrong. Advocate for policy change, advocate for human dignity, advocate for your communities, advocate for social justice, and most important, advocate for the person that is suffering right now.
Thank you.
So, the definitions that we chose for the purpose of this presentation was that harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with substance use. And also that harm reduction is a movement for social justice built on a belief in and respect for the rights of people who use substances. Joe touched on some of these, but the harm reduction principles are promoting public health interventions that minimize the harmful effects of substance use, understanding that substance use is a complex, multifaceted issue that encompasses behaviors from severe abuse to total abstinence, meeting people where they are at in the course of their substance use, ensuring that people who use substances have a real voice in the creation of programs, and affirm that people who use substances are the primary agents of change, and empower communities to share information and support each other. The goals are pretty simple. Just keep people safe, alive, free from infection, and reduce stigma. When we talked about what harm reduction is not, also pretty simple. It's not encouraging substance use. We think a lot about, you know, the same principles with providing condoms to teenagers. We're not encouraging teenagers going out there and being sexually active, but we just want people to stay safe. So part of harm reduction is reducing stigma, and that includes the way we communicate about addiction, its treatment outcomes matter to the individuals affected by addiction. Stigmatizing language can worsen addiction-related outcomes. And the role of clinicians, educators, and the community is to work towards destigmatizing stigmatization of addiction and its treatment. And the way we can do that is using non-stigmatizing language. We can also do that by role modeling as a better approach, and stop using outdated views on addiction, where it's viewed as more of a character flaw or moral failing, and more towards that of a chronic disease that requires long-term treatment. So Joe touched on some of these as well. Some of the examples of stigmatizing language are words and phrases like addict, junkie, things like that. And the proposed terminology to reduce stigma is phrases like persons with substance use, or addiction involving substances, person in remission from substance use, things like that. Another big one is the phrases like being clean or sober, alternative terminology being substance free, being abstinent, being in remission, and also trying to refrain from toxicology reports being referred to as dirty, and instead saying something like toxicology tested positive for a substance or tested negative, just to reduce that stigma. So harm reduction resources locally, we've referred a lot of our patients to Vivint Health. They have a number of harm reduction resources, which include their LifePoint syringe program, which utilizes a van where individuals can call. They will drop harm reduction tools off to them, which include fentanyl testing strips, Narcan, safe injection supplies. They even do harm reduction counseling and wound care education. It's a really great program that is across the state. Here is where they're located and the numbers locally. And then locally here in Dane County, Public Health also has a syringe service program where individuals can get sharp disposal boxes, drop off used injection supplies, and pick up safer injection equipment. And here are the locations in Dane County, which is mostly just Madison, 3 locations in Madison, for those public health syringe services. And then next we have Dr. Miller talking a little bit more about the future of harm reduction.
Thanks, Jamie. So, I mean, I think we've all have heard about supervised injection sites. They have a lot of terms, and we've been talking about like what is the best term from a stigma standpoint. Not everybody that comes into the supervised injection sites are actually injecting. They can be smoking, nasal. Is a better term overdose prevention centers or drug consumption rooms. I'm, after kind of doing some research for this, I'm really kind of liking harm reduction centers. So stay tuned for more terms for that. We're going to talk a little bit about naloxone. We all know that naloxone saves lives, but we're going to talk about how to get that out and expand it, and some things that are happening here in Wisconsin. Fentanyl test strips we'll talk about, some rapid access treatment for engaging people for medications for opioid use, and then just kind of leave you with some positive feelings with the Biden-Harris Harm Reduction Center and their recent response. So next slide. So, safe injection sites have been around for a while. They are not legal here in the United States. You can see that are in Europe, in the Netherlands especially, there are a lot. Our neighbor to the north, Canada, is also has done a great job with opening these and supporting these. But right now there are none currently in the United States. Next slide. So this is some data from Insight, which is the largest harm reduction center in Canada. It's in Vancouver. They are exempt from federal drug laws, and we'll talk a little bit about that. Since 2003, when it opened, they do have 3.5 million visits. They've had 6,400 interventions for using fentanyl and 0 deaths. So the numbers here are just huge and really exciting. And you can, it is busy. There's 312 injection room visits per day. But some places are even expanding to not just have that it's only just the safe injection site. Like, can you have access to treatment in there? Can you have testing for HIV and hepatitis C? Many of these places also give out Narcan and clean needles, so it's a great resource for people. Next slide. So again, like kind of here's just like the pros and cons, just what I was saying. Like we kind of all know what the pros and cons are. So obviously it's not legal here in the United States. There is a big controversy about it. Critics believe that it can make it easier for people who use drugs. And then people feel like it causes fewer related legal problems because people have a place to use drugs, and therefore people wouldn't get into treatment through drug courts. Next slide. So it is still happening underground here in the United States. There are some unsanctioned safe consumption sites. A lot of them are more out west. I don't know specifically where they are, but I've heard Portland, Oregon does have some. And I mean, you can see here, similar to the data from Vancouver, that there was 0 deaths, overdoses for total so far after the few years were overdose interventions were 33. So some recent stuff that's been happening in the news, Rhode Island is the most recent state approved at the state level just this past month in July of 2021 to approve a harm reduction safe consumption site in their state. So states can make the decision. However, this happened a few years ago where Pennsylvania also approved this, but then the federal law came in and trumped it. So the federal law came from this 21 US Code, whatever, 856, this Anti-Drug Abuse Act of 1986. So some people refer to it as like the crack house statute. It makes it a felony to open, lease, rent, use, or maintain any place for the purpose of manufacturing, distributing, or using any controlled substances. So that's kind of what the federal law states, and federal law kind of then comes in and takes over from the state level. So we're kind of going to have to stay tuned to see what happens in Rhode Island with different administration, hoping that maybe this statute can be changed, or they make an exception for safe consumption or harm reduction centers. Next slide. Okay, so now let's talk a little bit about Narcan. We all here do addiction work and know how Narcan works. This was a really interesting community study of Narcan, naloxone that was from a few years ago, but it was done in New Mexico. And they, at every visit, at an initial visit at OTP, like an opioid treatment program, and at one follow-up visit, they got opioid overdose education, as well as 2 doses of physical nasal naloxone to take home. So this was done at an OTP, but it's just kind of showing that, more naloxone in the community. So over that year, there was a 36% reduction in overdoses from opioids with more Narcan in the community. And they were able to compare that to some neighboring communities, neighboring counties in New Mexico, which had an increase of overdose rates of 125% and 253%. So from this Sentinel study in New Mexico, new legislation was passed. And so for law that every OTP patient now is mandated to get overdose education, as well as take home naloxone, as well as every patient leaving incarceration with opioid use disorder also gets take home naloxone. And as well as the new legislation shows that every police officer needs to carry 2 doses of naloxone. So next slide. So what's happening here in Wisconsin? So in 2013, the Wisconsin Act 200 provided that the Good Samaritan law, so if individuals use naloxone to reverse an overdose, it showing that they're doing something good and they wouldn't be having any type of legal ramifications from that. And then in 2015, Wisconsin Act 115, there is a standing order at any pharmacy if somebody would want to get a prescription for naloxone. However, it doesn't mean that the naloxone is free. So patients can go to a pharmacy and state that I'd like to get naloxone or an infected family member. They still have to pay for it. Depending on what pharmacy you go to here, it could be between $100 and $150. It's very expensive and can be difficulty to pick up due to the cost. So, Medicaid does, and most commercial insurances do cover naloxone at a very small copay, but those are only for people who do have insurance. So cost is a huge issue. The naloxone Narcan company does have a Narcan Direct program that many counties are using to buy Narcan naloxone people can get it at a cheaper price, but they still have to purchase it. And that's about $50 for a box, which has 2 doses. So it's still very expensive. Here locally at Dane County Jail, they do give 2 doses of take-home naloxone once patients with opioid use disorder get discharged. A big issue with some of the naloxone distribution to people is a labeling requirements from the pharmacy. I don't know the specific statute, but there is a statute in Wisconsin that states that all prescription medications need to have a label on it with the patient's name and instructions on how to use that. So this has been like going back and forth with a bunch of people from pharmacy and some of the lobbyists for UW Health trying to inquire about this. And so recently I kind of thought about like, what about people who you prescribe like expedited partner therapy for STDs? Like if you see somebody that has chlamydia, you can give a prescription without somebody's name on it. So interesting enough, there was an exception to that statute specifically for expedited partner therapy. So hoping that naloxone will eventually kind of have this exception be put on it, but there's a long way to go with it. People are kind of hoping that eventually naloxone will become over the counter, so it can become more available for folks. And people do think that maybe that would happen before kind of changing statutes. Naloxone obviously has been shown to be really safe. There's not many medications you can probably say this about, like, but if somebody got their hands on it, like a child, and used it, it has not been shown to have any negative consequences. So as well as like the future for funding, DHS has been working with Narcan Direct and a lot of recovery organizations helping to fund more naloxone in the community. I'm going to show you a really cool video in a second about the nalox boxes. DHS also funds hepatitis and HIV screening, testing, condom use, like new syringes, and they will also collect old syringes. They also pay for PrEP, educational material, and recently they started covering fentanyl chest strips. So next slide. So I thought this is how we're doing time-wise. This is like 1 minute and 30 seconds, but it does, okay, I think I'm getting thumbs up. Can you play this, Jamie?
Soon, all across Wisconsin, you may start seeing some of these boxes. It's an opioid rescue kit, and inside is Narcan, and that will help somebody going through an opioid overdose. Chief Joseph Adamson of the Horicon Police Department has responded to many overdose calls in his career. He carries Narcan with him everywhere.
You never know when you're going to run into an opportunity to help save a life.
He was excited to help install one of the first public opioid rescue kits in Wisconsin inside the lobby of his station.
Where do we have fire extinguishers? Places open to the public. Where do we have defibrillators? Places open to the public. Where do we have first aid kits? Places open to the public. Why not have this life-saving resource right next to each and every one of those resources we provide our public citizens?
Advocacy groups agree. Outreach specialists with Wisconsin Voices for Recovery have now put up 12 opioid recovery kits at places like gas stations, hotels, and multiple healthcare locations.
People can just come in, grab a dose if they know somebody that needs it, and just have it on hand with them.
They teamed up with ServeURx, a Milwaukee-based pharmacy, to install those kits. Inside, there's a nasal spray version of Narcan, instructions on how to use it, and information on how to get help for recovery.
So if we can get out there and get these boxes installed, it kind of helps to destigmatize opioid addiction, and helps people, be able to walk into places that our boxes are and just take the Narcan, no questions asked.
Jessica Geschke with Wisconsin Voices for Recovery says since those boxes have been installed, Narcan has been taken from 2 by someone to have, just in case.
In Madison, at one of our hotel chains, where an individual actually did overdose in the hotel, and he was revived with the Narcan that was there, and his life was saved.
A saved life from an overdose means that person can get the help they truly need.
Because you can't address problems if the person isn't with you anymore.
Reporting in Horicon, Andrew Havranek, Spectrum News.
Yeah, so that was from maybe a year ago. Since then, Wisconsin Voices has installed over 20 boxes, and DHS thankfully is going to fund this for the next calendar year. And starting this fall, we're going to be expanding this to places throughout the state of Wisconsin. So that's really exciting. So fentanyl test strips. So these are something newer that has DHS has recently started covering and has gotten a lot of press recently, especially with all the fentanyl that has been around that we have seen. So that they kind of look a little bit like the urine dipsticks. There's not a ton of studies that have come from this because it is newer, but really a lot of this is that when somebody does have positive for fentanyl, which you can see from the photo where it's just one small line versus no fentanyl, really is kind of talking about educating the patient to maybe then not use alone, making sure that they use with somebody who has naloxone, or to use less. So people talk about splitting the shot or using a smaller amount. People also then say to maybe not give it IV, not use it IV. So really a lot of it is like that harm reduction because of the fentanyl. So next slide. This is a small pilot that some data that from Milwaukee DHS that published. It's a little bit confusing, the data, but first it was initially piloted in Milwaukee for about 6 months in 2019, and then it kind of went statewide, but only for 2 months. 683 individuals received strips. Of the 170 individuals, only 25% gave the results. So of these positive results, if you look at the little chart, knowing that, so 42% of the people pushed the plunger more slowly when they had a positive for fentanyl. 79% pushed the plunger part way. And some people sniffed instead of shooting. Some people threw away the drug. You can see the numbers there. Used with a friend, used less than planned. You can see that the numbers are different than from the people who had negative for fentanyl. Fentanyl test strips are something new and a lot more research and data, and anything like in addictions, like, oh, more research is needed, more data is needed. So this is just one more thing, do these save lives? So that information is still questioning, but I can only imagine that the answer is yes. So next slide. So also kind of like just wanted to touch on this is just like rapid access to MOUD. So this is just low barrier of getting patients into treatment with buprenorphine product or Vivitrol or even methadone. So it's really kind of the goal, kind of what Jamie was talking about meeting patients where they are at. More and more emergency rooms are initiating buprenorphine. Many DHS is working with a lot of hospital organizations and funded them to start emergency room buprenorphine initiation and then getting them connected to care within a few days. There's also in other states, specifically New Jersey, EMS now is initiating buprenorphine after an overdose reversal with naloxone. So after somebody gives naloxone and they're in withdrawals, then to give the first dose of buprenorphine with a follow-up appointments the next day. So, these things are great, but we also need more access, more providers, more waivered people to prescribe buprenorphine to get these people in. Mobile MOUD units have really shown to be success, again, to kind of meet people where they're at. Colorado has a great mobile telemedicine group of people who are going out and people have really engaged, as well as San Francisco, their team of street medicine having an open access clinic for people to kind of engage in care has been really tremendous, and hoping that one day that we'll see some of these things in Wisconsin. Next slide. So kind of just leaving you with this little taste. I'm gonna just leave it here and not read it to you because we want Katie to kind of talk and have a little bit of time for discussion. But hopefully that with new different priorities with the new administration to help with opioid use disorder and harm reduction. So Katie, you're up.
Great, I'm going to share my slides. Okay, great, I see a thumbs up. Okay, great, well, thank you. I'm thrilled to be able to present alongside others who are involved with so much harm reduction. I am Katie. I'm a social worker at, I physically work out of the medical specialties clinic, but I'm available to work with patients anywhere at UW Health. So providers in any clinic, in any department can refer a patient to me. And I specifically work a lot with people who take PrEP. And so we'll talk a little, as has been made clear, PrEP is an important part of harm reduction, and we'll talk a little bit about how that works and how I may be able to help someone access it. So first of all, what is PrEP? I don't want to assume we all know, so we'll talk about a few of the basics. It's HIV pre-exposure prophylaxis. PrEP is a once daily medication that when taken as directed, it is highly effective. I see a question pop up, but I'll address the questions later on the full screen. I can't see the chat as we go. So I will respond to questions at the end. But currently it's indicated for adults and adolescents who are currently HIV negative, but at substantial risk of acquiring HIV infection. And we'll talk in a second about how to define substantial risk. So right now there are two medications that are approved for PrEP. There's Truvada, which also is available in generic form, and then there's Descovy. Right now, Truvada and generic Truvada is the only medication that is approved for use for people of all genders. Descovy is particularly useful if a person has elevated creatinine or a otherwise compromising kidney condition. So we won't get into the details there. Most people will be able to take Truvada or it's generic and have no issue there. The medication works specifically by concentrating itself in high levels in both the bloodstream, genital tract, and rectum to stop HIV cells from entering and replicating in a person's body. When a person's risk is through sexual contact, a person's risk of HIV infection is through sexual contact, maximum concentration is achieved in 7 days if it's for anal sex, it's 7 days in rectal tissue, and cervical, vaginal, and blood in 20 days. So if a person's risk of HIV infection is through blood-to-blood contact, potentially sharing injection supplies, or if it's through vaginal sex, 20 days of taking the medication as directed once a day to achieve maximum efficacy. And what is its efficacy? So I said it's highly effective if a person's rate of HIV, a person's risk of HIV exposure and potential infection is through sexual contact. When taken as directed, PrEP is over 99% effective at preventing infection. If a person's risk is more through blood-to-blood contact, such as injection drug use, the efficacy of PrEP, regardless of whether it's Truvada, the generic, or Descovy, is about 75 to 85%. So that's highly effective. You know, a lot of people oftentimes when I talk about this, people will be like, oh, you know, I wish that 70 was the 99 too. Of course, we all wish that, but 75 is still, that's a high number. That provides someone a lot of protection that without this medication, they may not have. So it's an important thing to be talking about if you're a provider with patients, if you're, you know, a person in the world who interacts with people who may be using drugs. This is an important piece to know about to help keep them safe. So because of this high level of efficacy, PrEP has received a grade A rating from the United States Preventative Services Task Force. And like, this sounds great, it looks good, right? Grade A rating, that feels really nice. This has a lot of implications, particularly with insurance, which is very important when it comes to patient access. So PrEP is covered by insurance, but just as Alison was describing with Narcan, just because it's covered doesn't mean it's affordable. When it was given this grade A rating, that put a little more pressure on insurance companies to cover this as preventative care. Just a few weeks ago, July 19th, 2021, United States Department of Health and Human Services issued guidance directly related to PrEP and its grade A rating, that if an insurance company is going to be compliant with the Affordable Care Act, they need to be covering PrEP at no cost share to the patient. And when we talk about no cost share, it's not just the medication itself. For the most part, that's fairly easy to get at no cost. If your insurance, or if you don't have insurance, there's drug manufacturer programs, but it's often the care that surrounds it. So people who take PrEP typically have 3-month labs, so they're getting lab tests and STI screenings every 3 months, sometimes every 6 months, but that's several times a year. They're having regular office visits, typically every 3 months, sometimes every 6 months with a provider, and those are the costs that can really add up for patients. So many of the people that I work with, this has made a big difference, right? Like having kind of the weight of a federal recommendation and having very recent guidance that insurers need to be covering it. This makes a big difference in making it accessible and affordable to people. So who is a candidate for PrEP? We talked about adults and adolescents who are HIV negative, but at substantial risk. How might we define substantial risk? So this is from the CDC's PrEP guidelines. They are categorizing it into two categories. There's the risk through sexual exposure, and then there's risk through injection drug use. So if a person has had any type of sex, anal or vaginal, in the past 6 months and has a partner who is HIV positive or has a recent bacterial STI or has a history of inconsistent condom use, they could be a good candidate for PrEP. You know, a lot of times when I've spoken with providers and I talk with people who are taking PrEP, and sometimes particularly patients have reflected, like, you know, when they start taking it, like, I just like never thought that this was for me. I thought this was like only for people who, you know, were the partner of someone who is positive. And And that's not, I mean, yes, that's true. It can be great for those people, but it can also be great for a much broader group of people. So when we think about these guidelines, I think that there's a lot of people who could be a good candidate. When the CDC, the way they define it, who's a candidate for PrEP if a person is injecting drugs, if they're doing so with a positive injecting partner, or if they're sharing supplies with someone. You know, and oftentimes these two categories can mix, right? You know, like someone could be a person who injects drugs and also could be a person with a recent bacterial STI. So, you know, there's multiple ways that that potential risk can show up, and there's multiple ways that a conversation about PrEP or access to PrEP can make a big difference in someone's life. So if you are a provider, I do see a lot of UW Health names on the list of attendees. If you are a provider, I'm happy to provide these slides. There's links to all the guidelines. The link at the bottom is to the CDC guidelines for how to prescribe PrEP. I'm also happy to put anyone in contact if you have questions specifically about prescribing with my colleague Rose Staden. She's a nurse practitioner in the infectious disease clinic. From one prescriber to another, she can give you some good tips on how to manage it. So what is PrEP navigation, right? We've been talking about this medication. I'm not the prescriber. I'm a social worker. What is my job? What am I doing with patients? PrEP navigation is patient-centered care coordination. So many of the people that I work with are not used to accessing healthcare, and our healthcare system is very complex and it's confusing, and there's so many different moving pieces. And so much of what I do is to help guide folks through our healthcare system. Okay, great. You've got your first appointment. What pharmacy do you want to use? Here's what you say when you go to the pharmacy to pick up your medication. Okay, you're coming in for labs. This is what you can expect. This is where you should go. Our healthcare system is often not set up as a one-stop shop. There's multiple pieces that need to fall into place, and I'm here to help guide someone through it. As I help guide someone through it, we can overcome both structural and social obstacles to timely and efficient, effective care. So insurance issues are super common. I work with people, as I said, I physically work in the infectious disease medical specialties clinic at the hospital. We see people for PrEP in our clinic, absolutely. I also get providers in any other clinic can refer patients to me. If you use HealthLink, there is an order for PrEP navigation that you can send through HealthLink to directly connect someone to me. My contact information is like two slides ahead, I think. But so insurance issues that come up, transportation issues that come up. You know, sometimes pharmacies will call someone, they need to talk to them, they need to confirm every 3 months before they get a refill. Some people, that is never going to work with their schedule. They're never going to be able to answer the call. They're never going to be able to call back. Sometimes those calls come to me instead. We obviously have a conversation about that, but that's part of why I'm here, is to provide individuals the support they need to the type of HIV prevention that they are looking for. Oops, I didn't mean to do that. We're almost done though. So what does PrEP navigation look like? I've mentioned working with insurance, helping folks understand how to use our healthcare system, how to use their insurance if they have it, how to get insurance if they don't have it. There are copay cards. So this is becoming a little bit less common because of the grade A rating, and insurance companies are covering it at less cost to a patient. But there are drug manufacturer copay cards that if a person, if their insurance says, oh, it's a $50 copay for a 1 month supply, these copay cards turn that into zero. So it's a great benefit. It's easy to do. Most regular people in the world just don't know it's an option. So I'm here to help provide that information. I provide a lot of reminders and check-ins. So it looks like it's time for a refill. It looks like it's time for labs. Do you have a plan of where you can go to do your labs? I'm in Madison, specifically in Dane County. We have quite a good network of local resources to ensure affordability. So I've talked a lot about insurance. If a person doesn't have insurance, I can, of course, help them find a plan that works for them. But sometimes people don't want to get insurance, or sometimes they're not open to that. And so if someone doesn't have insurance at all, I typically refer people to Vivint. Vivint has more flexibility as a as a community organization versus a traditional healthcare system to see people who don't have insurance. Sometimes we have folks who they have insurance, but it's like the cost of using their insurance is too high, or they just don't want to have to deal with their insurance. So all the labs that are needed for PrEP, all the HIV tests, creatinine tests, the regular STI screenings, all of those are also available at Public Health of Madison-Dane County. So we have plenty of people who go there for their labs. We fax them over. I get a lot of referrals from Public Health. So once again, I'm available to work with anyone who is interested in taking PrEP or who has questions about it, regardless of whether or not they are a patient in UW Health Infectious Disease and regardless of whether they are a patient at UW Health. I am happy to work with people to help connect them to find a provider and resources that work for them. So once again, if you are a provider at UW Health, you can use the PrEP navigation consult order. This is also my contact information. So my email's at the bottom. My mobile number is the best way to reach me. You can reach out anytime with questions. So I will stop sharing. I saw some questions pop up in the chat. I don't know if those were particular to what I was saying or just in general. Would it be appropriate for me to answer the questions?
Do you want to go for that? Yeah, go
okay?
for them. Do you want me to?
Okay.
I can read them to you.
Okay, sure.
So Elizabeth states that if someone denies sharing drug preparation or injection equipment, would PrEP conversation still be recommended, and would it be covered? Good question.
If someone denies sharing supplies, is PrEP still indicated? Sure. I mean, like, it depends on like what, I mean, are they a person who is sexually active, who has inconsistent condom use? That could be a reason to talk about PrEP with someone. Do they had a bacterial sexually transmitted infection? That could be a reason to talk about PrEP with someone. The second piece of that question, is it still covered? To my knowledge, like the conversation, the question of, you know, who's a good candidate and, you know, who's it indicated for, that's like provider discretion. That's a conversation between a patient and a provider. I have never seen any insurance deny coverage because there's no history of STIs or there's no history of injection drug use or something like that. If, you know, the deciding who's a good candidate, that's the part that's between the provider and the patient. I've never seen any insurance deny coverage based on that reason. And, you know, just as a side note, I talk about insurance as kind of being a hassle sometimes. Badger Care is fantastic. The people that I work with who have Badger Care pay less than anyone for PrEP. So a lot of people have Badger Care, so a lot of people have affordable access to PrEP.
Great. And I guess related, and I'm sorry, now I'm going to add on a question. If people have really sort of chaotic drug use and are concerned about their ability to remember to take a medication, I would assume that that would make it less effective, which to Joseph's question, that may be part of why we see lower effectiveness. But is that, I guess, because I'm thinking, you know, just for most people we see who are injecting drugs report not sharing, but, you know, always there are circumstances in which someone could share. But I think the other piece of the conversation would likely be like, can you remember to take something regularly, kind of with everything going on? And so I'm curious if you could comment.
Yeah, that's a great question. So the difference in efficacy is less about like perfect versus typical use, and it's more about like the chemistry in our bodies, right? So if a person's risk is through sexual contact, it's like less direct, right? Blood and blood touching each other is a more direct route to a potential infection, which makes potential the sharing of injection supplies. That's why that efficacy is lower, because it is like high risk is not, I don't want to use that term, but like it's a more direct way for HIV to potentially enter someone's body directly into their bloodstream versus through like rectal tissue or vaginal tissue. So to that point, the difference in efficacy is because of the way the drug works in our bodies and the way it interacts with our cells versus, you know, something coming in direct contact with our blood. the other part of your question of like, yeah, is it hard to remember to take a pill every day? Totally. Yes, that's an issue. There are a couple, so there's a couple of different, on the CDC, I'm happy to share these slides. You can even Google like CDC PrEP on demand. So on-label use, right? The only way to prescribe PrEP is daily use. Does everybody take it daily? Absolutely not. This is like totally unscientific information, but there's kind of like a general, like the general attitude among a lot of patients is if you take it 4 times a week, you're doing pretty good. So there is still, I often tell patients, this is not a zero-sum game. Maximum efficacy, taking it every day. Of course, is your provider probably going to always tell you take it every day? Of course they are. That's how it's meant to be prescribed. But we know that that doesn't always happen. So there's a lot of data, particularly in Europe, from studies in Europe, about PrEP on demand or event-driven PrEP or 211 PrEP. So what that is it requires some foresight. Like you have to have a plan, like you have to know when you could potentially be exposed. So you have to know, okay, I'm going to see a new partner on Saturday, or I know I'm going to be using on this particular day. That doesn't always happen, but in the event that you know that's going to happen, a person can take 2 pills the day before, 1 pill the day of, and 1 pill the day after. And efficacy for 211 PrEP is, again, these studies in Europe are showing it's roughly in the high 80s, 80% effectiveness. So it's not that 99%. It's not, but it is, and that's, through through sexual contact. So we know that doesn't always happen. We encourage people, we talk about different ways, reminders on your phone, pill container on your keys, stuff that I know none of that's new to any of you. But yes, we know that people don't always take it every day. It's not a zero-sum game, and there's still benefit to taking it. I think that a key is, I know the providers that I work with in the infectious disease clinic are really open to having those conversations with people. Not every provider is, some patients will come in and they'll be like, I'm never going to take this every day. I only want to do 211. And being able to have a conversation about that is really common and helpful. So if a provider has questions, yeah, go ahead.
Can I put a plug into that? I've prescribed it for people who are actively using and have, less consistent adherence. I would just say, it's benefit risk, but test them frequently for HIV. Because you wouldn't, theoretically they might be at higher risk if their adherence is poor, and you wouldn't want to go on sort of indefinitely not catching an active new infection.
Yeah. Good plug. Thanks, Kelly.
So it does look like our time here is up. It's lots of discussion, lots of thought. We'd love to hear, we were hoping to save some time to kind of talk a little bit about like some of the harm reduction things or harm reduction projects that are happening at your community. So if you have any cool projects and you want to share them, I'm not exactly sure what, maybe send them to us or send them to Heather, wherever this link is from, and then she can, she's going to kill me. You can send them to me. How about? I'm just kind of like, I'm curious because, we're always looking for new projects or new things and what people are doing that's out there. That's cool. I would love to be able to share that. So thanks for coming.
Thank you, everybody. This is a fantastic topic and good to learn from everybody.